Thanks very much. Thanks very much for asking me. I'd like to start by acknowledging the traditional owners of the land we're meeting on, the Camaragal people of the Eora Nation, and pay my respects to their elders past and present. I'd also like to acknowledge the gap in health and life expectancy between Aboriginal and non-Aboriginal people and the importance of doing something about that gap. So I'll try to leave enough time so you can ask some questions, and I'm not going to go into a lot of detail, very little detail about the content of my research. I'll be talking more from a personal perspective about my experience as a clinician-researcher throughout my life and the journey that I've gone on, like we've just heard. So it's a very personal perspective. I started my independent clinical career in Bourke. Now, Bourke's about 800 kilometres northwest of here, for those of you who don't know where it is. It's a town on the edge of the arid zone of Australia, and it served about, at that time, about 6,000 to 7,000 people. And it was pretty busy. I was a pretty busy clinician. We had been kind of prepared for dealing with difficulty. We'd worked in Borneo. My wife had also worked in Papua New Guinea. So we had 4 children while we were in Bourke. We had 3 pregnancies, so twins amongst those 4 under the age of 5. And the clinical work was pretty unrelenting. And I began my research, really was triggered by a colleague, a radiologist who visited Bourke, came in by plane and read our films, our X-ray films. And he commented on the number of children, infants, that he was seeing with pneumonia. And so I went back and had a look in the records. I audited the clinical records and found that the incidence of pneumonia in children, in Aboriginal children, was 8 times higher than the incidence in non-Aboriginal children at that time in the town. And I also went through death records, which was really interesting. It went right back to the turn of the century. So that's 1900s, not the more recent turn of the century, for those of you who are. And incidentally, by the way, the most common cause of death for infants around the turn of the century was teething, which is quite extraordinary. Anyway. A side anecdote. So I wrote this up, and I received some help from colleagues in writing this up. And there was also a medical student who helped me do who was with me at the time, who helped me write it up. And I published it in the Medical Journal of Australia. This is the paper. Now, the MJA at that time, its impact factor now is about 4, but its impact factor then was, I think, about 2. It wasn't, the peak journal in the world, but it was, and I think in Scopus I had a look, and it's had about 11 citations, which is pretty ordinary, but it reached the practitioners that were working in the field. It reached other doctors working in Aboriginal health, and it led to some further work. I actually got involved in WHO's acute respiratory infection program as a result of this paper, and did some consultancies in the Pacific region and in Southeast Asia over the next 10 years around their acute respiratory infection program in children as a result. But it also got me interested in Aboriginal health. And I was very interested in the change in Aboriginal health. There'd been a couple of GPs who preceded me. Teddy Cooligan, who whose son's still an orthopaedic surgeon here at this hospital, I think, and who became an emergency physician, I think, here at North Shore after leaving Bourke. But he had done a study in the late 60s, and there's another GP, Max Kamian, who subsequently was a psychiatrist actually, a psychiatrist and a GP who'd done some work in the mid-70s. And what they wrote about was quite different from what I was seeing. In fact, when I read Max's book, which was called The Dark People of Bourke, which was a kind of, it was meant to be a critique really on the way in which non-Aboriginal people viewed Aboriginal people in the town. There was quite a lot of racism and so on. He wrote this book, and the sort of health problems he described were quite different. And I thought, has he made this up? Because he wrote the book was published in about 76, I think, and I was there in the 80s, and it was just radically different from what I was seeing. And so I went on somewhat foolishly and started my doctorate, which I did while working as a clinician. I used to go up I get called in the middle of the night to go to the hospital to see someone, and I'd come back, and rather than go back to bed, I'd go to the practice where I had my Apple IIe set up, and I was going through tabulating records and writing papers and things. And I received a lot of, and that's what I did my doctorate on. And there's a lot, I was really exploring not only the change that had occurred in that 10-year period, but also, more importantly, some of the reasons for that. The association, for example, with there was actually an increase in the incidence of pneumonia, a decrease in a lot of other infectious diseases. It was related to some changes in housing and water supply and unemployment and so on. And I won't go into the detail of that. If any of you are interested, you can have a look. And I received a lot of support, and support. I had to kind of develop my methods and my expertise particularly in, because this was really largely descriptive work, sort of comparing changes over time. I had to use and develop different methods. And I had to also conduct the research in collaboration with the Aboriginal community. This was a time where we really barely had ethics committees. So the whole, certainly didn't have bodies like AHMRC. The AHMRC statement on Aboriginal research was about 10 years, 15 years later. And there was, so the whole idea of doing research in collaboration with Aboriginal people, with disadvantaged and vulnerable groups, really was very poorly developed at that time. And it was a sensitive issue, and I had to be aware of the ethical challenges I was a clinician working in the town, and I was doing research. So, one of my studies I looked at, there was a family, Aboriginal family who had a particular condition in their family, and I was doing family trees. I had big cardboard things, doing family trees on them and so on. And that was quite a sensitive area. You can imagine even just who was the father of who was not without its sensitivity. And it was important that I did that research in collaboration with Aboriginal people in that town. And during that time I developed relationships and friendships which we've had for our whole lives. So unfortunately, some of those people have passed away. We left Bourke eventually, and I then worked for a couple of years. As I said, we'd worked previously in Malaysia and North Borneo, and my wife had worked in Papua New Guinea, and we worked for a couple of years in Vanuatu, which you probably think of as a kind of holiday resort. It was probably the hardest I've ever worked in my life, before or since. And I was a community health physician, really responsible for community health outside of the capital. And during that time, conducted, apart from my kind of day job, I conducted research, again, largely descriptive research, looking at prevalence of conditions, various conditions, pneumonia, meningitis, hepatitis B, and started to get interested in non-communicable diseases because we were seeing a rise in the towns, particularly in diabetes and heart disease. This is an example of some of the clinical research. There was some of you might have seen the movie Tanna. Anyone? No? Okay. Tanna is the southernmost island of Burke. It's got a volcano in it. People go there and get excited about the volcano. Yassur is the name of the volcano. But it has it had an outbreak of yaws. You've probably never heard of yaws. Yaws is a treponemal infection. So it's in the same family as syphilis, but it's what people imagine leprosy. Leprosy isn't anything like you imagine, for a start. But yours is what people imagine. It has ulcerating lesions that eat away at soft tissues and cartilage, and is very disfiguring, and is transmitted non-sexually and within close household relatives, and it's exquisitely treatable. It's treatable with penicillin, benzoyl penicillin. So penicillin injections. So we conducted a survey, and I think I've got it in my bag. Sorry, I'm moving outside the camera. I'm not supposed to do that. The community gave me as a result of the research we did, we got the New Zealand Army in, and we basically gave penicillin injections to the entire population, and which was a major feat, and really eradicated the disease from the island. And this was at a ceremony where they gave a presentation to the New Zealand Army, but also to me. They gave me this conch shell, which was meant to indicate my, sort of blowing the horn for alerting them to this condition and giving rise to a program which helped to eradicate it. So I came back to Australia and took up a position in University of New South Wales, located in southwest Sydney. We had a clinical department out in southwest Sydney, and I continued to conduct descriptive research. This was the first study on anxiety and depression, believe it or not, in general practice patients, which produced estimates of prevalence and how it was being managed at that time. And I started to get more and more interested in long-term conditions, both their prevention and management, and became interested in the organisation between models of care and quality of care. So this led on to more policy-orientated research that was focused on how general practice was organised, funded, and the systems that supported GPs to provide better care, information systems and so on. And it led to more involvement with policymakers, which is an experience. They're a completely different world to clinical care or research, and that was very interesting. It also, at that time, began to understand that if we're going to do research, particularly research at scale, that's got the ability to potentially transform practice in not just one little location but across the health system, that we needed to have some systems to support that research. So registers, we were involved with primary care registers for diabetes at that stage, establishment of cohort studies. I was involved in the setting up an Aboriginal child health cohort study, and also I was involved in the early days of establishing the 45 and up study, which is a longitudinal study still going on, run by the LACS Institute, and it is a tremendous resource for this sort of research, particularly because it's got data linked to it, not just the data that's collected as part of the cohort study itself, but it's got all of the health service data linked to it. I also started to get more involved with establishing networks of clinicians who were supporting research. Initially, we started off thinking about, every clinician has got a topic that they're interested in, and supporting that. And that's obviously a good thing to do, but we found that at scale in general practice, because general practice is so broad, that quickly, your efforts become quickly really dissipated, and it's very hard to do research at scale. So within those networks, really making decisions about what areas would be concentrated on at any one time was very important. I continued to look at research questions in my own practice. In 2000, I moved from southwest Sydney onto campus and started doing clinical work at the Asylum Seeker Centre, which is a non-government organisation that provides care to refugees who are asylum seekers who don't yet have Medicare. So they don't have entitlements of Medicare or the pharmaceutical benefits system and so on. In fact, at that time, they didn't even have access to public hospitals, although that was subsequent, about 8 years ago, that was, they were able to get access to public hospitals. And I continue to work there 1 day a week. And despite the political heat, at that time there was very little written about the health of asylum seekers, or even refugees more generally living in the community. There was a bit of work more on what was happening in the detention camps, which are obviously highly political, and also on what was happening to people's health overseas as refugees overseas. And I began to supervise more students and gradually take more of a backseat role. So my kind of position in the order of authorship moved to the end rather than the beginning, which is as it should be. And like Aboriginal health, this is a highly sensitive area of research, and we had to take a lot of measures to protect confidentiality and their concern about refugees are often concerned not just about their privacy in general, but they're very anxious about government. Many of them being persecuted by government. Many of them are still worried about their governments persecuting them from agents within Australia. And that's a reality, unfortunately. So you can imagine the sort of issues that they confront and the way in which we need to do research. Recording interviews, for example, audio recording interviews is something we don't usually do because of that. Like Louise, throughout my career I've received support from and mentorship and people who've acted as role models, not just in research expertise, but really, and leadership, but in my life. And so Charles Bridges Webb, the first there, is a GP academic who'd worked in rural practice before becoming an academic. He initiated really the first descriptive research on general practice in Australia. And he and others set up the Beach study, which some of you may have heard of, which was running until recently still out of Sydney University. And he mentored and guided me. He was my supervisor for my doctorate, and he's also been a great role model. Unfortunately, he passed away a few years ago. Ian Webster is a public health physician whom I work with and for at the University of New South Wales and in southwest Sydney. And he's mentored and guided my career, and in fact still chairs our advisory committee for our centre and is a great inspiration. Committed, he again shows that commitment to the nexus between clinical practice and research and advocacy. Martin Rowland, the third along, is a GP academic in the UK. He's now at Cambridge, but he was at Manchester running the National Primary Care Research Centre, and I spent some sabbaticals with him and visited him and seen him numerous times, still see him at conferences. And I learned a lot about, not just about conducting research and the technical side of things, but more importantly, leadership. He's also, I'll come back to this, but he's also someone that said to me, Mark, you can't do everything. He has visited us and provided a lot of support for us. And lastly, Barbara Starfield, who conducted really groundbreaking research in the 1990s in the US, which is somewhat ironic given the parlous state of primary care in the US. It's not as well developed as it is in the rest of the world, really, partly because of the funding system. She really showed, though, what a difference primary care could make to both health and the health system. And she's also highly committed to health equity. And she passed away a few years ago as well, but she visited several times and gave us a lot of support. So there are many others who have provided support, and I hope that you have got not just one mentor, but that over your careers you develop mentorship and support from a number of people, and that will be really important to your success. So in 2006, so still more than a decade ago, we brought together, we had some research units that were working collaboratively, and we brought them into a single centre. In developing countries in rural Australia, I'd learned a great deal about what could be achieved with limited resources, and it made me aware of some of the deficiencies in Australia and the need to make a difference at multiple levels, at the level, not just the policy level, at the national level, but regional, local practice level. And research and development were critical. One of the things I learned when I was in Vanuatu was, and to some extent in Burke, that documenting what you do, publishing what you do, is one way of helping to sustain the learning that you have. Otherwise, it tends to get forgotten. So you might do great things, but unless it gets published, it's likely to be forgotten, which is a sad truth, but something to keep in mind. So we developed an approach to research which was embedded in partnership with health services. So we've got research units within the centre that are embedded in local health districts, in primary health networks. And so when we talk about translation, we're not really talking about translation. The research we're doing is with and of those services, not just, so we're not kind of sitting in a laboratory over here doing something and then thinking, gee, how do we get people to do this? We're actually doing it with them. And that's, we found, is a very useful model. I wanted to end with some lessons, which I've alluded to already. One is about role boundaries, and this is not just about ethics committees, which are the bane of my life, unfortunately. I'm sure any of you who've done research will understand how difficult dealing with ethics committees can be sometimes. But about the boundary issues and being clear about the different roles and thoughtful about that, reflecting on what that means and how we need to behave as clinician researchers, both in our clinical work and in our research work. And also working in partnership with consumers, especially where these are vulnerable consumers, working in partnership with communities and consumers. Being objective while acknowledging your role as a clinician and the experience you've got. Pursuing rigour and seeking all the expertise and support and mentoring that you can get to achieve that. Learn as much as possible from your positive and negative findings. The things I've learnt most about have been the studies which didn't have the result that I expected. They're the studies that have helped me to understand and really, particularly because I'm working increasingly at the health system level, about how you can make change and transformation and what some of the constraints are. And accept that you can't do everything, as I said before, and accept that being a clinician researcher can give you some understanding and credibility, but also you can get negative comments and some degree of resistance or negativity from some of your clinician colleagues. You've just got to be able to roll with that. It's not always support you get. Thank you.